Self-regulation really is a critical component to a profession. And in order to maintain the public's trust in our self-regulation of medicine and in particular the specialty, we need to have a process that's very transparent and visible to others on the outside, both the members of the profession and also the public. And so who knows what the profession should be doing better than the doctors in that profession. So I think although the board certification process and continuing certification still, it's an evolutionary process and may not be perfect, but it's the best we've got and is far better than some external organization trying to control what doctors do, don't do, and so on. I wasn't there personally, despite being pretty old. I wasn't there when that happened. But my understanding is that ear disease was a major problem. Mastoiditis, infections, and that could be life-threatening very easily. That was a significant issue. So I think what happened is back, I think in the 1800s, the ophthalmoscope was developed. And so for one time, doctors could look inside the eyeball and see what was going on there. And along the same time, perhaps a little bit later, the otoscope, same type of device to look in the ear to see what's going on in the ear, and the laryngeal mirror, so that one could examine the larynx in a patient that was awake and talking. I think those things allowed doctors to see something that couldn't be done in any other part of the body. You kind of had to guess what was going on based on palpation or whether there was tenderness or things like that. So for the first time, you could actually see things. At that time, there was not much of an organized educational program in the United States. And so for otolaryngologists, the ones who were able to travel to Europe, to Vienna and other places like that, where advances were being made in ear surgery. And so that was the way that people became trained, but there was no standardization. The Flexner report was in 1910, and Flexner, who was a non-physician, was charged to look at medical education in the United States, and his report was quite damning of the wide variety of standards for medical education in medical schools, not graduate medical education. Anyway, as a result of that, many medical schools closed. The quality of medical education of those schools that stayed open improved, and I think that then translated into training after medical school. There needed to be some sort of standardization for that. It's my understanding from the work that the Triological Society did, and I think it was also the American Academy of Ophthalmology and Otolaryngology, that they decided to put together a committee to see what they could do about it. And the charge to the committee was to set up standards for education in the residency programs in ophthalmology and otolaryngology. The ophthalmology group took a little different track. They decided to set up standards for testing, and so they established the first board. The otolaryngology group followed what their assignment was and set up standards for training. Ultimately, that led then, a few years after the ophthalmology board was established, to establish the Board of Otolaryngology for testing. So in the 1950s, the specialty was expanding into head and neck surgery and facial plastic surgery and other areas. And the term otolaryngology tended to reflect the old practice of otolaryngologists. The new practices of particularly head and neck surgery were not well reflected in the name. Um, the specialty was making progress in these areas and clearly showing that it provided excellent care for patients in those areas. My understanding is in the 1980s, the board somewhat unilaterally changed its name to the Board of Otolaryngology Head and Neck Surgery, but that was not well received at the ABMS, and the board decided to withdraw that name change. Continuing into the 90s, and when I was in practice, there still was a lot of conflict with the general surgeons over head and neck surgery and with the general plastic surgeons over facial plastic surgery. But progress is really being made because people do recognize when there's quality of care. So during my tenure, I made a point of developing good relationships with all of the executive directors of the other boards, and particularly with the board the executive directors of the Board of Facial Plastic Surgery and Surgery, because we had so much overlap. The last couple of years of my tenure, I worked with them to try and see if they would not oppose the change of the name. And they recognized that indeed it was an appropriate name change because our journals, our departments, the academy had all changed their name to Otolaryngology Head and Neck Surgery. And so I was pleased when, right at the end of my tenure, the ABMS approved the name change. And it's something that I'm particularly proud that I was able to contribute to the board. Well, first, I'd like to compliment my predecessors who did this job on a part-time basis while running their full-time practices and other aspects of their lives. They really did make a great contribution to the board. However, the board recognized that the world was changing. The ABMS was taking a stronger role in determining what the boards needed to do. Some of the issues that we were facing were more complex. And so the board decided to hire a full-time executive director, and I was fortunate enough to be selected for that position. So it was something that I think the board needed to do, and it's really a good sign that they recognized that and made the decision. During my tenure that I'm very proud of is we improved the examination process, the oral exam. We developed using the computerized testing for some of our exams, and we improved the visual presentation at the oral exam, which made those visuals much more useful. MOC was something that was mandated by the ABMS, and the board recognized it was an important concept, but wasn't yet quite fleshed out how to do it so that it was meaningful and yet non-obtrusive to the diplomates. We were very slow and deliberative in how we established it, but still it was not a popular thing with many of the diplomates. So although it was frustrating at times, I think it served as the basis for what is now a continuing certification, and I think is better accepted by the diplomats. It was an interesting process, and for the most part occurred during my time on the board. I was elected director in 1990. It was becoming clear that, particularly in the areas of pediatric otolaryngology and neuro-otology, that there was a proliferation of fellowships that some of which were excellent and some of which were not excellent. And so a member of the board, a man I respected greatly and has been a big influence on my life, Ron Bailey, established the Education Council. And it was sort of a otolaryngology think tank, and one of the first projects we looked at was the proliferation of fellowships and some way of standardizing that. And so it's sort of a two-step process. In other words, we had to set the standards for the fellowships, which is something that the ACGME does. Bruce Gantz took on neurotology, and I led the charge on pediatric otolaryngology to get standards set for fellowship training in those two specialties. That took a little while, but it was accomplished. And then with, again, Bruce Gantz taking the lead on neurotology, the board developed a neurotology sub-certification exam. And obviously with any change in anything in our lives, there's controversy, but it certainly has borne out to be something that is very important and of value to the public.